Hello, everyone. Welcome to my 12-month progress report. I'm going to talk about strategies in coronary artery bypass grafting in patients with acute myocardial infarction. So my name is Lieberman Judith. I'm a first-year PhD student and a medical doctor. I'm representing the Department of Cardiovascular Medicine and Research. These are my team who are helping me to achieve my goals, my vision and mission, which are provide the highest standard of care for patients in acute coronary syndrome and comparing outcomes across different timing strategies. So those are my two ongoing projects, which I both have started in the autumn of 2024. My first project is investigating the optimal timing of coronary artery bypass grafting in patients with acute myocardial infarction. So about the background, acute myocardial infarction is one of the leading causes of mortality in the developed world, with around 3 million deaths per year. So coronary artery bypass grafting, or in shorter form, CABG, is an essential surgical intervention in order to restore normal blood flow. We have to compare the risks of early and delayed surgery. As I mentioned, both have advantages and disadvantages. In early CABG, there is improved revascularization and reduced size of infarction. Late CABG, we have time for the patient to stabilize hemodynamically, and we also leave time for the myocardium to recover from necrosis. Disadvantages is increased perioperative risk, bleeding, myocardial injury, and even death. For late CABG, there is increased risk of recurring ischemia, heart failure, and sudden cardiac death. And as the time is passing, the infarct size will extend and will leave a larger myocardial damage. So on the figure, you can see that there is a U-shaped curve. So we are trying to find the golden time window between these time frames. So my clinical question is, what is the optimal timing for performing CABG in patients with acute myocardial infarction? I was using a PFO framework here. The patients are acute myocardial infarction. Patients who are undergoing CABG, factor is different timing for CABG, and outcomes are mortality, different postoperative complications, and length of hospital stay. We hypothesize that early coronary artery bypass grafting in myocardial infarction patients is not inferior to the late intervention. My clinical and research implication is to decrease the mortality rate and the different postoperative complication rate. This is my final search key, which has been conducted in 3 different databases, and I divided them to 3 domains: the myocardial infarction, the CABG, and for the timing. Those are my key articles. Which outcomes have matched my interest of outcomes? So about my flowchart selection, we have started with more than 10,000 articles and ended up with 33 eligible full text. And then we found 8 additional ones from the citation chaser with my selection pair. So about the progress of my first project. The data extraction has been finalized, but some editing is necessary because my data is really heterogeneous. But meanwhile, I finished the risk of bias. So my second project is investigating the effects of body mass index on postoperative complications in patients who are undergoing cardiac surgeries. So a bit about the background. So I think in healthcare, everyone knows that obesity is a large problem, and the global prevalence of obesity has nearly tripled from 1975 to 2021. In 2021, 39% of adults were classified as overweight and 13 as obese. Extreme BMI values significantly increases the risk of coronary artery diseases. Individuals who has a BMI over or equal to 30 have a 64% higher likelihood to developing it compared to those who have a normal BMI. And risk for coronary artery diseases are more than 1.5-fold in those subjects who have a BMI under 17. So both obesity and being underweight complicate the surgical care patient. They are facing unique postoperative challenges, and our aim is to investigate how BMI is influencing postoperative complications and recovery in open heart surgery patients. My clinical question is there a higher risk of postoperative complication in patients with extreme BMI values? Here I also use PFO framework. Patients undergoing open cardiac surgery factor is body mass index, and the outcome is different postoperative complications, atrial fibrillation, wound healing, and also mortality. So on the clinical and research implication, we are focusing on personalized care, risk stratification, and planning for long-term management. So we would like to personalize this whole management plan. And we hypothesize that patients with extreme BMI values, either underweight or obese or morbidly obese, they have a higher risk of postoperative complications following an open cardiac surgery. So this is the search key, which also has been conducted in 3 databases, and I divided them to 2 domains for the cardiac surgery itself and the body mass index. Those are the key articles that are matching also my outcomes of interests. So after that, sorry, I didn't mention, I would like to, our next step is to check if the project is feasible. And to summarize, I would like to finish my first project in December and the second one next year. So, and I would like to close my presentation with a quote from Winston Churchill, that success is not final, failure is not fatal, it is the courage to continue that counts. And thank you for your attention.
Congratulations to the nice presentation. Are there any questions from the audience?
So congratulations for the nice study. And my question would relate to both of your projects because the pharmacological management based on the different guidelines. And as far as I know, there could be differences and even updates in the guideline whether which type of therapy pharmacological management applied for the patient. And my question is, how does it influence your data, whether this is suitable for any subgroup analysis?
Actually, we didn't consider pharmacological treatment in these populations. We subgrouped them on different factors, like, for instance, that how many vessels were necessary to be transplanted, or their ejection fraction, or their left ventricle function. So, but pharmacological treatment we didn't include in this project.
So then this would be a kind of recommendation as the guidelines has been updated and there are just some changes, so it could influence even in the discussion of the paper.
Yes, I was also thinking about, because basically all of those patients are on ASA, clopidogrel, and this. So, yeah.
Okay, thank you.
Thank you.
Thank you very much. Any other question?
Congratulations to the presentation. I would like to ask you what do you think about what would be the contribution of the general anesthesia versus the cardiac surgery to the risk of the intervention in the high BMI patients in your last project?
So the general anesthesia and?
Versus the surgery itself. So the
So
question is that
which one is the bigger risk?
Exactly, because if it's anesthesia, then it's other surgeries as well, right?
Yes, on this project we are only focusing on cardiac surgery, but of course anesthesia, general anesthesia itself is a bigger risk factors for those people who have extreme BMIs. And so like anesthesia is already a stress factor, but then the surgery itself and the recovery is also modified for these people considered to someone who has a normal BMI.